Welcome to Introduction to Shock. All living cells in the human body require oxygen in order to efficiently convert glucose to energy. In order for cells to receive oxygen, there needs to be adequate blood flow throughout the body so that oxygen-rich blood can deliver oxygen to the tissues and cellular respiration can occur. When there is impedance in the body's ability to perfuse blood to the tissues, shock may occur. Shock is the result of circulatory failure throughout the entire body, which results in cellular damage and can lead to multiple organ failure if not treated immediately. Blood pressure is a major determinant of the perfusion of tissues. There needs to be pressure to push blood into the capillaries of each tissue. Blood pressure is determined by two factors: resistance to flow and cardiac output. Resistance to flow is determined by the length and width of the vessels, as well as the viscosity of the blood. Cardiac output is determined by heart rate and stroke volume, meaning the amount of blood that's pumped out with each beat. Diffusion is a passive process in which molecules move from an area with a higher concentration of molecules to an area of lower concentration. This is how oxygen and carbon dioxide cross the walls of the alveoli. The majority of oxygen is carried to the tissues attached to hemoglobin. Carbon dioxide can be transported in the blood from tissues back to the lungs in one of three ways. It's either dissolved in the plasma, combined with water in the form of bicarbonate, or attached to hemoglobin. Carbon dioxide waste products released from cells can combine with water in the bloodstream to form bicarbonate. Once it reaches the lungs, the bicarbonate breaks back down into carbon dioxide and water, and then the carbon dioxide is exhaled. Perfusion is the passage of fluid through the circulatory system or lymphatic system to an organ or a tissue. This usually refers to the delivery of blood to a capillary bed of tissue. Perfusion is measured as the rate at which the blood is delivered to tissue, or volume of blood per unit of time, per unit tissue mass. When something interferes with the body's ability to perfuse, shock is the result. At the end of the day, the only thing that kills us is lack of perfusion. Shock refers to a state of collapse and failure of the cardiovascular system that leads to inadequate circulation. To protect vital organs, the body directs blood flow from organs that are more tolerant of low flow, such as your skin or intestines, to organs that cannot tolerate low blood flow, such as your heart, brain, kidneys, and lungs. Early recognition of the signs and symptoms of shock can save lives. Shock is life-threatening and requires immediate recognition and rapid treatment. That's where EMS comes in. Here we have the circulatory system. To simplify this, it helps to think of the circulatory system as a pump, some pipes, and its contents. It consists of the heart and a complex arrangement of connected tubes. This system would include arteries, arterioles, capillaries, venules, and veins. The circulatory system is entirely closed and, like the lungs, is a pressure system. There are two circuits in the body. Systemic circulation is blood that travels throughout the body. It carries oxygen-rich blood from the left ventricle through the body back to the right ventricle. As blood passes through the tissues and organs, it gives up oxygen and nutrients and absorbs wastes and carbon dioxide. The elimination of cellular waste when blood goes to the liver and kidneys is one of the systemic circulation system's functions. Pulmonary circulation means that blood is only traveling between the heart and the lungs. The passage of oxygen-poor blood from the right ventricle through the lungs back to the left atrium causes a gain of oxygen and a loss of carbon dioxide as it passes through the lungs. Blood pressure is the pressure of blood within the vessels at any moment in time. Systolic pressure is the peak arterial pressure, or pressure generated every time the heart contracts. Diastolic pressure is the pressure maintained within the arteries while the heart rests between heartbeats. Pulse pressure is the difference between the systolic and diastolic pressures. It signifies the amount of force the heart generates with each contraction. A pulse pressure less than 25 millimeters of hemoglobin may be seen in patients with shock. Blood flow through the capillary beds is regulated by the capillary sphincters, which are circular muscular walls that constrict and dilate. These sphincters are under the control of the autonomic nervous system, which regulates involuntary functions such as sweating and digestion. Capillary sphincters also respond to other stimuli such as heat, cold, the need for oxygen, and the need for waste removal. The regulation of blood flow is determined by cellular needs. However, perfusion also requires adequate oxygen to exchange in the lungs, nutrients in the form of glucose in the blood, and waste removal, primarily through the lungs. Blood pressure may be the last measurable factor to change in shock. When a drop in blood pressure is evident, shock is already well developed. Remember, this is particularly true in infants and children who can maintain their blood pressure until they have blood loss that is more than half their blood volume. Keep in mind that by the time blood pressure drops in infants and children who are in shock, they are already close to death. In its simplest form, shock is inadequate tissue perfusion. This means that oxygenated blood can no longer reach the tissues and the cells to support normal metabolism. Normal body function requires that cells receive a sufficient supply of oxygen, glucose, and nutrients to produce energy. Metabolism of oxygen and nutrients produced waste products, such as carbon dioxide, which must be removed. This exchange of oxygen and carbon dioxide, nutrients, and waste products is known as perfusion. Adequate tissue perfusion requires that 3 legs of a perfusion triangle all be functioning. These legs are the heart, the vasculature, and oxygenated blood. If any of the 3 legs of the perfusion triangle fail, perfusion suffers. And there are many ways that this can happen. Looking at the heart, the patient could experience a heart attack or heart failure. Either one of these can make the heart weak, which impairs its ability to pump blood throughout the body. With the vasculature, the blood vessels can dilate, so the same volume of blood is present in a much larger container, reducing the blood pressure and impairing tissue perfusion. Lastly, blood or fluid can be lost, either through trauma, diarrhea, vomiting, or other problems, all of which can reduce the blood pressure. Whatever the cause, the cells don't take this insult lying down. Although oxygen and glucose allow for the most efficient production of energy through a process called aerobic metabolism, there is another option. In anaerobic metabolism, meaning without oxygen, cells continue to produce energy and metabolize. But there are problems with this backup system. It simply doesn't produce as much energy, and it also produces metabolic byproducts, such as certain acids that are harmful. It's not a good long-term solution to poor perfusion. To simplify it even more, aerobic metabolism results in the creation of 36 ATP. ATP are the building blocks of life. They're what give us energy. It takes 4 ATP to create any ATP within the cell. Therefore, with aerobic metabolism, you net 32 ATP. With anaerobic metabolism, you only create 6 ATP. If it takes 4 to go through the process, you only have a net gain of 2, meaning eventually you'll run out. Let's take a look at some of the compensatory mechanisms that the body has. As the heart begins to fail, the body's compensatory mechanisms attempt to improve cardiac output by manipulating the following: your preload, afterload, cardiac contractility, and heart rate. Ultimately, however, the compensatory mechanisms may actually worsen heart failure. The sympathetic nervous system will boost the heart rate, increase the force of contraction, and constrict the blood vessels. This accelerated heart rate and stronger force of contraction will increase the heart's oxygen demand, reduce the amount of time the ventricles have to fill, and decrease time for coronary perfusion. Additionally, stimulation of the renin-angiotensin-aldosterone system by decreased blood flow to the kidneys means the heart has to work even harder to pump against the high pressure. Aldosterone encourages sodium and water retention and increased blood volume, meaning increased preload. These compensatory mechanisms do increase cardiac output for a time, but eventually heart failure will advance. The sodium and water retention will actually enlarge the heart's chambers. The ventricle walls will thicken, which will weaken the force of contraction. This will result in a weakened contraction, and then the heart is unable to handle the increased volume of fluid, and eventually cardiac output will fall. Now that we've looked at the compensatory mechanisms, let's take a look at shock itself. There are 3 different stages of shock. Stage 1, also called compensated or non-progressive. Stage 2, decompensated or progressive. And Stage 3, also known as irreversible. In Stage 1 shock, low blood flow is first detected, and a number of systems are activated in order to maintain or restore perfusion. The result of that activation is that the heart beats faster. Breathing also increases, and the blood vessels throughout the body become smaller in diameter. Lastly, the kidneys will work to retain fluid in the circulation system. The patient is likely to be awake on the AVPU scale, though they may have an altered mentation, such as confusion, irritability, or lethargy. Because the body is attempting to maintain critical systems, such as the heart, brain, liver, and kidneys, you may notice changes in the patient's skin condition. Pale skin, cool skin, and blue-tinged lips are the result of inadequate perfusion of the skin. These compensatory mechanisms serve to maximize blood flow to the most important organs and systems in the body. Since the patient is compensating, the patient's blood pressure is likely to be within normal limits. The patient in this stage of shock has primarily vital sign changes, and aggressive treatment may slow progression. In Stage 2 of shock, these compensation methods begin to fail. The systems of the body are unable to improve perfusion any longer, and the patient's symptoms reflect that fact. Oxygen deprivation in the brain causes the patient to deteriorate to V, P, or U on the AVPU scale. Heart rate and breathing rate are still above normal, and blood pressure may be close to normal or below normal. In Stage 3 of shock, the length of time that poor perfusion has existed begins to take a permanent toll on the body's organs and tissues. The heart's functioning continues to spiral downward, and the kidneys usually shut down completely. The heart rate and respiratory rate are well above normal until crashing to low rates incompatible with life. The patient's blood pressure is also precipitously low. Cells and organs and tissues throughout the body are injured and dying. The endpoint of Stage 3 shock is patient death. Here we have the three causes of shock: pump failure, poor vessel function, and low fluid volume. This series of lectures is going to focus on pump failure and poor vessel function, as low fluid volume is typically covered in other lectures. We're also going to discover central versus peripheral shock. Central shock consists of cardiogenic or obstructive shock. Cardiogenic shock occurs when the heart cannot circulate enough blood to maintain adequate peripheral oxygen delivery. The most common cause is myocardial infarction, and cardiogenic shock may be due to either a single event or cumulative damage over time. Obstructive shock occurs when blood flow becomes blocked to the heart or great vessels. When a pericardial tamponade occurs, diastolic filling of the right and left ventricles is impaired due to significant amounts of fluid in the pericardial sac surrounding the heart. Decreased ventricular filling leads to a decrease in cardiac output. Aortic dissection leads to a false lumen with loss of normal blood flow. A left atrial tumor may obstruct flow between the atrium and ventricle and decrease cardiac output. Obstruction of either the superior or inferior vena cava decreases cardiac output as it decreases venous return. And a large pulmonary embolus or a tension pneumothorax may prevent adequate blood flow through the lungs, resulting in inadequate venous return to the left side of the heart. Peripheral shock includes hypovolemic shock and distributive shock. In hypovolemic shock, circulating blood volume is insufficient to deliver adequate oxygen and nutrients to the body. And there are two types, exogenous and endogenous, meaning it just depends on where the fluid loss occurs. Exogenous is external bleeding. This is the most common type of hypovolemic shock. Endogenous shock occurs when the fluid loss is contained within the body. Distributive shock occurs when there is a widespread dilation of the resistance vessels, the capacitance vessels, or both. Here, circulating blood volume pools in the expanded vascular beds, and tissue perfusion decreases. There are three common types: anaphylactic shock, septic shock, and neurogenic shock. Anaphylactic shock, also known as anaphylaxis, is where histamine and other vasodilator proteins are released upon exposure to an allergen. This will also be accompanied by wheezing and urticaria. Widespread vasodilation causes fluid to leak out of the blood vessels into the interstitial spaces. Septic shock is the result of a widespread infection, usually bacterial. If normal immune mechanisms become overwhelmed, the body produces a multitude of substances that cause vasodilation and decreased cardiac output. If left untreated, this will result in multiple organ dysfunction syndrome and death. Neurogenic shock usually results from spinal cord injury. Here, we have a loss of normal sympathetic nervous tone and uncontrolled vasodilation. Most types of shock are characterized by reduced cardiac output, circulatory insufficiency, and rapid heartbeat. Determining the presence or absence of shock requires the evaluation of the presence and volume of the peripheral pulses and the assessment of end organ perfusion and function. The strength of peripheral pulses is related to both stroke volume of the heart and pulse pressures. Normal skin perfusion should result in warm, dry, and pink extremities, fingers, and toes. Shock may result in slow, delayed, or prolonged capillary refill time. To test this, briefly squeeze the toenail or fingernail to look for a return of color. Normal refill time is less than 2 seconds. Mottling, pallor, peripheral or central cyanosis, and delayed capillary refill may signal the presence of shock. Remember, the accuracy of capillary refill measurement decreases after age 6 and is not useful in the patient or in the adult population. However, measuring end-tidal carbon dioxide may be one of the most useful tools for the astute clinician. Here, we interpret the effectiveness of perfusion based on changes in capnography and capnometry. Decreasing levels of end-tidal CO2 are an early indicator of shock. Low levels of end-tidal CO2, combined with other signs and symptoms of shock, such as hypotension and altered mental status, are ominous clinical findings. Multiple organ dysfunction syndrome, or MODS, is a progressive condition that occurs in some critically ill patients. It is characterized by concurrent failure of 2 or more organs or organ systems that were initially unharmed. There are 6 organ systems that are surveyed in diagnosing: respiratory, hepatic, renal, hematologic, neurologic, and cardiovascular. The disease process often progresses in a cyclical method, including multiple organ systems and complicating factors. Overall mortality rate varies widely depending on the underlying etiology and ensuing diagnosis and treatment. The major cause of death following sepsis, trauma, and burn injuries is MODS, with mortality rates of up to 70%. There are 2 types: primary MODS and secondary. Primary MODS is the direct result of an insult, while secondary MODS is slower and more progressive organ dysfunction. MODS occurs when injury or infection triggers a massive systemic immune, inflammatory, or coagulation response, accompanied by endotoxin release. Overactivation of the complement system will further increase inflammation and cellular damage. Overactivation of the coagulation system causes uncontrolled coagulation in the microscopic venules and arterioles. Additionally, bradykinin, a potent vasodilator, is released, and this vasodilation leads to tissue hypoperfusion and may contribute to hypotension. The net outcome of MODS is the maldistribution of systemic and organ blood flow. It's not uncommon for MODS to develop either hours to days following resuscitation. Signs and symptoms may include hypotension, signs of insufficient tissue perfusion, uncontrollable bleeding, and multisystem organ failure. During 14 to 21 day period, renal and liver failure can develop, along with the collapse of the gastrointestinal and immune systems. Patients may require continuous bedside dialysis, and there is no definitive treatment for the liver failure. Essentially, treatment is going to focus on minimizing the effects of the damage. The brain, adrenal glands, and the heart are affected much earlier. Hypotension cannot be controlled, and as such, cardiovascular collapse and death typically occur within days to weeks of the initial insult.